Great. Off you go. Thanks.
So I think that everything that you've all reflected on about Abby while thinking in your groups is I completely concur. I mean, there was, as you picked up, there was this massive staff anxiety, which is why they placed her in this glass room. They were just fearful that she would die and it would be their responsibility. Nobody had really recognised or really considered how to explore with Abby what was important to her, what her insights were about her illness, and who the important people were in her life, or anything really about her. They didn't know it, and they hadn't the skills really, or the understanding about how to approach that. So she had no trust in anybody. She was very, very isolated. So yeah, absolutely. What she needed was for people to just spend time with her, talk to her, and really explore that. And that's exactly what happened. So we had, I mean, it was just phenomenal, really. So the palliative care nurse and social worker spent time, but they also had hostel staff with them at the time. So her key worker came in with them, and so they understood how they approached Abby, and it was initially completely about just building some form of rapport, and finding out what was important to Abby, who was important to her, a little bit about her past, whatever she was feeling safe enough and happy enough to share, and also what she really wanted and what she liked. And they found that she hated hospital. She was really fearful of hospital. She'd had a lot of friends who died in hospital. It was the last place she wanted to be. She absolutely detested being in the glass room, and her privacy was she felt really she'd lost everything, including now her privacy and her dignity. And she liked art. And so they basically managed to work with the hostel staff to move her back into her own room, so she had her privacy. They spent time understanding. They referred her officially to their palliative care team, so which meant they could work with her more because they felt she was. And they also referred her to the art therapy in the day centre, and had to work quite hard with the hospice to enable her to go, because there was a lot of fear within the day centre as well. So they had to do quite a lot of training within their own organisation to enable this to happen. But over time, basically, Abby also, she said she wanted to engage with the GP, but thought she'd been given up on. She actually wanted to consider hepatitis C treatment, but she felt it wasn't really an option for her because her GP didn't have any faith in her. And she ended up basically, she's still alive today, basically. Abby, this is 3.5 years later, and I do really think from what was going on, she would not have been alive for another 6 months, the way her health was deteriorating. She's not going to hospital she's not needing to go to hospital. There've been no emergency admissions, apparently to this day since then. And she's engaged now. The hostel staff felt much more empowered to know how to talk to her, how to be more aware, person-centered, trauma-informed. And the palliative care team had a massive learning curve as well. This was a huge, they never quite worked with anyone with such huge complexity as Abby. And so everyone sort of really benefited and felt that support. So it's not rocket science. It was absolutely, as everyone here has said, it was about spending that time, getting to know her, seeing the need for developing some form of relationship and trust, and taking it one step at a time, but also removing this anxiety. It's not a hostel staff's role to fix somebody's problems, removing this anxiety that everyone has got to be treated and get better, and immediately that can have an impact. So I think it's this, and we found this with a lot of people that we've worked with, outreach staff and hostel staff, that by just thinking actually differently and in a person-centered way, helping people explore their insights, can take away a huge amount of the burden and fear and anxiety they have, and enables them to actually work much in a much more supportive way with people. So that's really, I think, an amazing outcome really for Abby, and I wish we could have many more projects all over the country working in the way that those staff did. So
wow, what an amazing conclusion. Thank you. Are there more questions for Caroline and Briony? Anything? Yeah, we have a question from Anne. Thank you, Anne.
Sorry, it's a really basic question, but I'm really interested to know how the palliative care nurse and social worker were kind of introduced. What was said about them and their role?
that is not a basic question. That was a really critical, difficult area, actually. So, yeah. So when they're coming into in this role, they were not coming in as they hadn't. They're one of the big barriers is getting consent for somebody to then invite palliative care in. So I'm so glad you raised this, Anne. So and there was a lot of discussions around this. And in the end, what we did was we had consent. The hostel staff asked Abby if she'd be happy to talk to some people who were health professionals who might help explore what would make things better for her. And they weren't introduced as palliative care staff. Once they were there and they were involved, then they could talk about palliative care and what they can offer as palliative care nurse and social worker. But I think it's something that I feel we have a real problem with terminology with palliative care. And I think that we also have a problem where people can't refer to palliative care services, which is often the case, I think, without consent from the patient. And that in itself is very difficult, when actually what we would like is those referrals to come from people like frontline staff, hostel staff, who really are not, it's not a fair request for them to start having to explore why somebody might benefit from palliative care. And it also, they probably would like a conversation with somebody to explore, would this be an appropriate referral? This is somebody that I'm really concerned about. This is what's happening to them. So I think they didn't originally go in and say they are from palliative care teams until they had an opportunity to explore that with Abby themselves. But it was quite difficult to kind of define how that should work. And I think within this project, they weren't there as they weren't, the people they were seeing in the hostel initially were not on their caseload. Once they were referring somebody onto the caseload, then it was clear that there was that relationship and they were the palliative care professionals. Does that kind of answer your question or make any sense?
Yeah, no, I mean, it sounds lovely. It just struck me that it was, I mean, it's a difficult concept to explain to anybody, really. And I'm just thinking about this, you know, Abby, you know, must have been feeling so completely physically rotten and, you know, and so down to sort of, so to, you know, it was, I think that sounds like a lovely way to convey, you know, what you needed to without, you know, without worrying or complicating it. Yeah.
It does raise the whole issue of hospices and compassionate communities, doesn't it? You know, really, you know, I was one particular hospice that I work with are absolutely right in the community, and they're very well aware of hostels. You know, we have to promote this much more, don't we?
Probably have time for one more question if anyone has anything that they'd like to bring. Taking it right up to the wire. I do have a question. One of the early slides was about non-engagement and how that can be managed in a trauma-informed way. That feels like a real dilemma, especially with the kind of funding crisis and the kind of pressures on us to use our time efficiently. And I just wondered if you had any thoughts about what a trauma-informed response to multiple missed appointments might look like.
Yeah, I mean, this is a really, really tricky one. And I think what can be really hard. So when I was working in primary care and a specialist primary care, and I would say to people, look, you've missed an appointment. I'm going to, you know, they've discharged you. Look, I can re-refer you, but, you know, it's really important you go to, and they'd say their self-esteem was so low. They say, oh, don't bother. Obviously, I'm not worth it. And it would be a response. So picking up immediately this, immediately turning around what I had said to that was meaning, you know, should I bother to re-refer you? So it's really hard, actually. It's really hard because I think and I don't really know what the answer is, except maybe working with peer-led organisations. So there are some organisations such as there's Groundswell works in a lot of boroughs, and that's basically got people who have lived experience of homelessness, and they and a number of local authorities or number of trusts fund Groundswell to support people to appointments, and having you know, working out if there are any peer groups within your locality, because they are really helpful ways of supporting people to appointments, because there's many reasons why people won't go, and a lot of it is related to fear and anxiety, fear of rejection, and all the other barriers that we've come across. It's a very alien environment, you know, and I think it's how can we make that less fearful, and I think, you know, working with peers is a really good way to do that. So yeah. The Groundswell.
Thank you so much. Yeah, that's really helpful. And we are nearly out of time, but I just want to say, Briony and Caroline, thank you so very much. And sorry, I'm stealing Rebecca's thunder because you were going to thank them also.
You
So
never
I'll
have
hand over
enough
I'm just
thanks,
delighted. Yeah,
Tina.
it's just a wonderful presentation, and really, I've got pages and pages of thoughts, and yeah, very inspiring.
Yeah, no, I just to agree with that, really. I mean, I said at the beginning they were, you know, celebrities for me, so I'm sure they're now for all of you as well. Just such a great mix, and all those resources at the end are just amazing. So much more to dig into, and just really sharing all of that with us, I think, is very generous. And yeah, look forward to seeing what we can all do with it. So the final thing just to say, apart from that big thank you, is about our next meeting, community of practice meeting, which will be on the 18th of February. And that's going to be with David Shemmings. And the topic is the relevance of trauma-informed approaches. So he's going to talk about the way past trauma can cause people to be more easily triggered in the present, for example, when they're getting a palliative care diagnosis or facing medical treatment. And he's going to consider how professionals who aren't trauma therapists, so that's lots of us, can build trust to engage with patients and help them emotionally self-regulate. So that sounds really interesting as well. So hope to see some of you there on the 18th of February at the same time, right, Jeanette, as normal at 1 o'clock?
Yeah, same time. Yeah.
Great. So that's in a month and a half time, 6 weeks. And that's it, I think. Is there anything else I'm supposed to say? It's my first time doing an intro and outro, so I'm
That was
I'm looking at my
perfect.
colleagues, if I've missed anything. But yeah,
It's
thank you all for
been
being
great
here
to
as
see
well,
you.
and really nice
Yeah.
to see you. Good start to the new year.
Yeah.
Thanks for
Yeah.
having us as well. So it's been great.
Thanks, everyone. Yeah.
Thank
Bye.
you. Bye-bye.
Thank you.
Bye.
Lovely to see you again.
Bye.
Thank you. Thanks. Bye-bye.
Thank you.
So we go back into the next link, right? Yeah.